Thank you very much for the invitation. Unfortunately, due to a lot of congresses and some social activities in Athens, I will speak today virtually. The title of my talk is Optimizing Inhaler Therapy in COPD. So you can see here the management cycle of COPD. First of all, you have to review the symptoms, the dyspnea, the exacerbations, and then to assess the inhaler technique and adherence, the non-pharmacological approaches, and of course, you have to adjust the treatment by escalating or switching inhaler device or de-escalate. So these three components may drive the maximum optimization regarding inhaler treatment for COPD. But unfortunately, for this disease, the disease is a complex disease with multiple components, and also is a multifactorial disease with many factors involving in terms of the etiology, like the pollution, the smoking, or even the infections, the pathogens, and also the environmental exposures, and of course the host susceptibility. On the other hand, there is a lot of other factors that may be involved in the pathogenesis of the disease, like the genes, the cells, the tissue, and also the organ by the daily symptoms and exacerbations. And if we want to divide the inflammatory process, there are two major components. One is the T1 or T17, which is a neutrophil predominant, while the other one is a T2 eosinophil predominant. And of course, we have always to consider that emphysema is a distinct pathology of the disease. And also we have the involvement of the small airway obliteration, the inflammation, the mucus plugging, and of course the fibrosis and the increase of airway smooth muscle. So by mentioning all these factors, just to clarify that it is quite difficult for the COPD patient to optimize inhaler therapy in a very great level. So when you start treatment and you see the GOLD guidelines or the GOLD consensus, you can clearly understand that there are two major factors that drive your decision in the initial phase. One is the symptoms, and the other is the exacerbations. And apart from the symptoms and exacerbation, there is another one, inflammatory module, which is the blood eosinophils. So no optimization, no mentioning other factors or other components that may affect the optimization of inhaled therapy. But when you start to follow up these patients, you can clearly see that we have two major routes. One is the dyspnea, persisting dyspnea. The other is the persisting exacerbations. So how you optimize the inhaler treatment by using these two components? For the first one is to consider to switching inhaler device, but without mentioning that the initial phase, you have to select the proper inhaler device, to implement or escalate the non-pharmacological treatment, to consider adding new bronchodilators, and the only one which is available is the ensifentrine, which is not available in Europe without authorization in Europe, and investigate and treat other causes of dyspnea. Regarding exacerbations, the only component that you use for driving your treatment decisions or changing your treatment decisions is the blood eosinophils. So you can clearly understand that the optimization of inhaler treatment depends either on the device or on the use of different devices, or on the use or on the adherence, or in blood eosinophils. So no other factors are mentioned in the GOLD consensus. So which are the key points for inhalations of drugs? First of all is the education, the training, the choice of inhaler device is a process where it is essential to provide instructions and to demonstrate proper inhalation technique when you're prescribing a device. And then you have to check the adherence. So all these factors, all these components, I consider them as quite critical when I discussed about the optimizing of inhaler treatment in COPD. So which are the basic principles for appropriate inhalation device choice? You can see, first of all, the availability, the patient's belief and satisfaction, the device type, to share decision making, to check whether the patient is ability to perform the specific inhalation maneuver, either for the DPIs or for the MTIs. And also other factors you have to consider is the portability, the cost, and of course, when you prescribe an inhaler device, you have to be in accordance with patients' preferences. So this is a very nice study published many years ago in the ERJ, and also is an ERS-based study, when you can clearly see by optimizing the inhaler treatment, the first approach is to choose the right aerosol delivery device for the patient. So it depends on the inspiratory flow, and also it depends in using the combination of the pure actuation and the inhalation coordination. And you can clearly see here the selection of the proper device, the deposition, and also you can see the inhalation flow. So you can clearly see that if you want to target the conducting airways, or if you want to target the larger airways, or if you want to use a DPI or MTI, you have to use these two components in order to select the proper device and to optimize your inhaler treatment. And this is another study which was published in the Blue Journal many years ago, which is a study involving three clusters. The first cluster represents patients with poor attempted adherence and high technique error rate. The second cluster represents patients with good attempted adherence and high technique error rate. And the last cluster represents patients with good attempted adherence and low technique error rate. And you can clearly see in this graph that the adherence is quite low, and also you can clearly see the rate of different errors, and also you can clearly see the frequency of errors. The first one is the low peak inspiratory flow rate, and you can see also the multiple inhalations, the exhaling to mouthpiece, or the blister present, no inhale detected. So you can understand that the second part of the proper or of the optimization of inhaler therapy is the attempted adherence and the technique error rate. And this is another approach, is a study published by Richard Derkusen just 1 year ago. It's a meta-analysis trying to see how you improve the aerosol drug management, and by using questionnaires or by selecting proper inhalation techniques. Another critical and important issue regarding the optimization of inhaler therapy is the cognitive and manual impairment. And you can clearly see in this study, which is actually a prospective study from the chest 1 year ago, that there are many findings which are mainly attributed to cognitive impairment, to manual impairment, and of course, in the suboptimal peak expiratory flow rate. So it's quite important to consider these two factors when you select an inhaler device. And do you need any other help? This is another study which was published in a journal which is mainly focused on pharmacists. And you can clearly see the effect of pharmacist-led interventions on medication adherence and inhalation. But sometimes when you select the inhaler route, and we select the device, and you have to check the adherence, you have to ask for assistance or for support from other health professionals like pharmacists. And you see here in this very nice overview of this meta-analysis that the intervention group using the pharmacy-led intervention showed a decreased rate of exacerbations, and also improve quality of life, and of course increase adherence. So how you improve the adherence of these patients? So today we are all discussing about artificial intelligence, and we sometimes discuss about the electronic adherence using specific inhaler usage pattern via AIM, and trying to check the adherence of these patients. And you can clearly see here a study which showed two intervention groups, and also some key outcomes about the adherence. And you can retrieve very valuable information. First of all, that the adherence rate is very low. And the second one, which is quite important, is that when the adherence rate is very low, you did not see any difference regarding symptoms and the quality of life using the CRQ or the SECQ questionnaire. This is a nice perspective published in the Blue Journal 1 year ago about pharmacotherapy, and it's trying to raise some issues about the highlights of COPD pharmacotherapy, and also how you increase the optimization using different pharmacological patterns, and of course using the major patterns of COPD treatment like the LAMA, LABA, and also the ICS. The first question is why you have to choose mono or dual treatment. How by the dual treatment, the double bronchodilation, the dual bronchodilation, you increase the optimization treatment. No effect on hospitalizations, minimum effect on exacerbations, but of course a major effect on symptoms and on lung function. But you have to consider, and this is a very nice review published by David Singh in the European Respiratory Review. But when you check the exacerbations, when you check the hospitalizations, or when you check the symptoms, you did not consider the reduction in risk of the clinical important difference in some of the components that we are using in our daily clinical practice for checking the optimization of inhaler treatment. So if you use the clinical important difference for different components, you can clearly see that the dual treatment is superior to a mono treatment of bronchodilation. And of course, you have to optimize your inhaled treatment by using new bronchodilators. And we have one, sensitefrin, which is actually a PD inhibitor, which has two major targets. One is the bronchodilation, and the other one is the inflammatory pattern. And also, there is some evidence published recently about the combined effect with LAMAs and particularly with tiotropium. So in the future, we have to optimize our inhaled treatment by using new bronchodilators, and new bronchodilators will have a component of anti-inflammatory pattern. And of course, by increasing inhaled treatment, by using the triple therapy, we showed some beneficial effects on mortality. But on the other hand, we have to consider that despite this beneficial effect, there is a supportive evidence from other non-pharmacological approaches, which are quite critical for the optimization of inhaled treatment. So we have the direct effect, and also we have some indirect effects. But last but not least, when we are trying to optimize our inhaled treatment, we have to consider that some patients may receive this optimization using a different endotyping mechanism or using treatable traits. And one treatable trait is the presence of eosinophils as absolute numbers. And we have this evidence from the triple therapy, where despite the fact that there is a beneficial effect in terms of exacerbations, in terms of hospitalizations, in terms of lung function, we can clearly see that this beneficial effect was more evident when we used some specific cutoff value of blood eosinophils. And this was actually observed in two trials. One is the ethos trial, and the other one is the impact trial, using two different triple devices. So you can clearly all see that the beneficial effect and the optimization from the inhaled therapy is also based on some subpopulations, like those who exacerbate and requiring antibiotics, and those who exacerbate and requiring oral corticosteroids. So the optimization of inhaled treatment, apart from the bronchodilator effect of the anti-inflammatory effect, has some indirect effects from treatable traits and from endotyping mechanisms. And this is just another paradigm that this is a sub-analysis, is a post-hoc analysis of the impact trial where the effect of chronic mucus hypersecretion is critical for treatment responses. So you can optimize the treatment by using different components coming from the inflammatory pattern. And also you can de-escalate the treatment by trying to reach the optimization by using treatable traits and by combining treatable traits like the blood eosinophils or the exacerbation. And this is actually the ERS guideline for inhaled corticosteroids withdrawal in patients with COPD. So this is my last slide. So when you optimize therapy to achieve improvements to the highest degree possible, you have to consider, this is an excellent study published by David Singh this year in the Blue Journal. You have to consider the clinical important difference. You have to consider all the components of the disease, but the major target is the disease stability and not the treatment-based changes in some of the components. So the treatment change, the treatment optimization leads to improvement. And of course, in some patients, we have the progression, which continues despite the treatment optimization. But the main target is the disease stability. It's I think, the worthwhile COPD treatment goal at all COPD stages. And this is also food for thought for the future. Thank you very much for your attention. And also thank you very much for the invitation in this excellent Congress. I hope that next year I will be with you physically.